So, chapters 22 and 23 in your textbook talk about the newborn, care of the newborn is chapter 23, and then those physiological changes that occur in the newborn, your assessment, and various things you're looking for are covered in chapter 22. I combine the two because there's a lot of topics that are discussed in each chapter that can be discussed together. So, instead of talking about them individually, they're going to be integrated together throughout this lecture. So the first thing we'll talk about is that transition. So there is a period about 6 to 8 hours after birth where you're really monitoring very closely for various different things, their ability to adapt to their environment. But there are stages that go through that transition period. The first stage is called the first period of reactivity, up to 30 minutes after birth. This is when baby is awake. They are paying attention to their environment. This is the absolute best time to start breastfeeding. You see, for those of you that have been in labor and delivery, you've seen where as soon as they make sure baby is stabilized, they put baby to mom's chest for that kangaroo care, the skin to skin contact, as well as if mom is going to breastfeed. This is the best time to start. They are active and awake, so that helps with them with their ability to be engaged in the process, as well as their ability to learn that instead of waiting till later. After that first 30 minutes or so, they'll have a very sleepy time period. They just went through something very stressful. They came out into the world. So this is a period where they will go into a pretty deep sleep and sleep for anywhere from 1 to 2 hours. And then after that, they have a second period of reactivity where they're more awake and interacting with their environment. And usually during that second period of reactivity, it's not where they're awake the entire 2 hour or 8 hours, I'm sorry, but they'll kind of go back and forth, maybe doze off a little bit and wake back up. But that first period of reactivity is important to start establishing those good habits, especially with breastfeeding. So in those first 2 hours, some of the care management things that we are doing, the very first thing we're doing when baby comes out, whether it be vaginal or C-section, is looking and seeing if they're breathing, doing just a head to toe quick over what's going on. I mean, you're doing that as you're looking at baby. It's not really a specialized assessment. And part of that you're getting that from is doing the Apgar score, which we're going to talk about in detail in just a second. That Apgar score lets you know, based on their heart rate, their responsiveness to stimuli, their respiratory effort, and things like that, how they're doing, how they are adapting to their environment. Some of the other initial things we'll do, we will look at their color. So their color is part of that Apgar scoring as well. Looking at drying them off. That is one of huge priority as soon as they are born because of cold stress. So babies cannot shiver and they can't sweat, so they do not have any kind of thermogenic regulation mechanisms yet. So in order to stay warm, they have to be kept wrapped up. That's why we keep hats on babies and keep them wrapped up. But also because of that evaporation that occurs from the amniotic fluid and all sitting on their body, as that evaporates, that will cool them off, kind of like when you sweat, the evaporation of the sweat cools you off. This is a cooling method that can really hurt baby, and we'll talk about cold stress in a minute, but it's not just about being cold for them. So doing that initial physical assessment, looking at an overview, getting their vital signs, getting their measurements. They'll get a weight, they'll get a length. We call it a length instead of a height because they're laying down. So you're measuring them head to their feet. They'll do chest circumference, head circumference. So various different measurements. They'll also do what's called a Ballard score, a gestational age assessment, and I will show you what that looks like in just a second after we talk about the Apgar. But this is where you're looking at various characteristics of the baby to determine a more accurate physical gestational age, as opposed to just using those dates to determine their gestational age. So going back to vital signs, make sure you know your normal newborn vital signs. Heart rate is still 110 to 160, just like it is as a fetus. Your respiratory rate is going to be 30 to 60 and irregular. And we're going to talk about respiratory in a minute, but their bodies are learning how to breathe. So what we talk about in adults, that Cheyenne-Stokes respirations where they're panting, and then they stop breathing, that is normal in a newborn. Their temperature is just like ours, 97.7 to 99.4. Blood pressures are typically 70s to 80s systolic over 30s to 40s diastolic. But that respiratory rate and that heart rate and that temperature are your really important ones that they want to know about. As far as assessment of the baby, on page 559 in your textbook, it shows some really good detail of those newborn assessment things that you're looking for. So I would recommend that you review that. Also, I posted on Blackboard a video of a newborn assessment of a provider doing a head to toe newborn assessment. It includes abnormalities you might see as well. So it's a really good video to show you that full newborn assessment. So if you haven't done one or you haven't seen one, I do recommend you watch that video. So let's go back and talk about that Apgar scoring. So Apgar is a scoring system where they get a score from 0 to 10. And it looks at 5 different characteristics or 5 groups of characteristics on the baby. The first thing is activity or muscle tone. The chart I have here says absent, arms and legs flexed, or active movement. Another way you may see it listed is if they have some flexion, like with the arms and legs flexed, they'll use that as muscle tone as well. So are they fully flexed where their arms, when you pull their arms up, do they spring back to them like you would expect a baby, or do they kind of limp down? The second one is their pulse. This is the only score that is actually a numerical based score. So when we're looking at heart rate, we're actually looking at what the heart rate is, what number it is. So 0 for no heart rate. They get 1 point if it's below 100 beats per minute, and then the full 2 points if it's over 100 beats per minute. So grimace is how they respond to stimuli. So if you rub their feet, or back in the day they used to smack babies on the bottom. They don't do that anymore. But when you irritate them or stimulate them, how do they react? If they just lay there, they're flaccid, then that's a serious issue. Versus if you go to rub their foot and they try to pull that foot away and they are actively moving around, that's a really good thing. It shows that they have a good grimace. They are responding well to stimuli. Appearance is based on their skin color. So this is oftentimes where babies lose a point. It's very not uncommon for babies to get a full APGAR of 10, especially at that 1 minute time period. And this is usually where they lose that point. So if they have what's called central cyanosis, meaning their face, their head, their lips, their chest are blue, that is where they get that 0 points. Central cyanosis. If they're pale or blue, if there is an indication of hypoxia. 1 point though is when they have acrocyanosis. So acrocyanosis is where their hands and their feet are blue. This is not concerning. It's very common. It just means they need to be warmed up. They're too cold. Their circulatory system is very immature. You'll hear that theme a lot in this lecture. A lot of immaturity in their systems, so they don't quite know how to regulate the shunting of blood to warm up their extremities. So if their extremities alone are blue, that's not concerning. You just need to warm them up. Either put them under the radiant warmer, wrap them up, whatever it be. If they're completely pink head to toe, they get 2 points. So respirations, like I mentioned, pulse is the only one that's based on number of heartbeats. Respirations category is not based on how fast they're breathing. It's based on their cry. So if they're not crying at all, they get 0. If they have a weak cry or slow cry, then they would get 1. If they have a really lusty, vigorous, strong cry, that gives them that 2. So all these categories go together to give you that overall score. They check the APGAR. At minimum, they'll check it on every baby at 1 minute after birth, and then at 5 minutes after birth. If there are concerns, like if they're below that 7, they can continue to do them more after that. But at minimum, they will do 1 minute and 5 minutes. So at the bottom of the screen, you see how those scores correlate. So an Apgar 7 to 10 means they're doing really well. They're adjusting well to their environment. No concerns there. As we get to 4 to 6, moderately depressed, meaning maybe they need a little extra stimulation. Maybe you need to rub their feet or be checking a glucose, things like that, to find out why they are not as responsive as you'd like. Severely depressed is the baby where you are going to be using your bag, bow, mask, and bagging for them. Because they are not doing well and they need resuscitation, severe resuscitation. So let's do an example of this Apgar scoring. So in this case, our question is: a nurse is assisting in the care of a newborn following birth. At 1 minute after birth, the nurse notes the following. So these are your baby's characteristics: a heart rate of 110 beats per minute, a slow, weak cry, some flexion of the extremities, grimace in response to suctioning of the nares, body pink in color with blue extremities. What should the nurse document as this newborn's 1 minute Apgar score? 4, 6, 8, or 10. So I will give you a minute. You can certainly pause the video so that you can think about it and add up your score, and then we'll discuss. So this baby right here would get a score of 6. So let's talk about why. So here's our Apgar scoring system again. Let's go and talk about those characteristics. So the first characteristic in the question is a heart rate of 110 beats per minute. So in the pulse category, any heart rate over 100 beats per minute gives them 2 points. So this baby gets 2 points for that category. The second characteristic listed in the question is a slow, weak cry. So if we go down to respirations, again, this is not based on respiratory rate. This is based on the strength of their cry. So if they had a good, strong, vigorous, lusty cry, they would get 2 points. But this baby has a weak cry. So they only get 1 point in that category for that. With the next characteristic in the question, some flexion of the extremities, this actually goes back up to activity or muscle tone. So when we're talking about the flexion of the extremities, if they are fully flexed, they get 2. But in this case, this baby is listed as some flexion. So they get 1 point in this case. When we're talking about the next characteristic of the baby, grimace in response to suctioning of the nares. So they're not grimacing in relationship to just their environment. It requires stimulation to make them grimace in this case. Is some significant stimulation. In this case, they only get 1 point for grimace because they are requiring that stimulation to make them agitated. And the last category is their skin color, their appearance. And this baby had a pink body in color and blue extremities. So in this case, they have that acrocyanosis. So they're centrally oxygenated because their central core of their body is pink, but they have the blue hands and feet. So in this case, they would only get 1 point for that. So our 2 points for the heart rate, our 1 point for the activity, 1 point for grimace, 1 point for appearance, and 1 point for respirations gives us a score of 6. So this baby probably needs a little bit of extra stimulation to make sure they are perking up, and sometimes they will. By the 5-minute one, they come around and they just take a little bit longer, but that's why they do it multiple times. So I mentioned the Ballard scale. I do not want you to memorize all the categories of the Ballard scale, but you will see some of the things again, like you'll hear about the scarf sign, for instance, and things like that. This is shown on your textbook as well on page 558 for you to refer to. So again, this is where they take the characteristics of the baby, and you can see those on the screen between their posture, how far they're able to flex their wrist, that scarf sign where you pull the arm across their chest and how far over are they able to pull it, as well as some of their physical characteristics, like how much lanugo they have, the creases in their feet and things like that. And if you look in the lower right hand corner, based on what score you get as you add those characteristics up, it gives you a correlation to what gestational age they are in physical means. So one of the things they do right away is give some medications to the newborn. Hepatitis B sometimes is given right away. Sometimes it does. It's given later, and we won't focus on that one as much. Hepatitis B, you are required to get consent for from the parent because it is a vaccination. The two medications here, though, are not vaccinations. They are required by law. So if parents do refuse these medications, I mean, it is their child, and occasionally parents do refuse. You have to well document these. But the two medications that every baby gets is the ophthalmic erythromycin and the intramuscular vitamin K. So erythromycin, we've talked about this one several times. This is for the potential for them to get neonatal conjunctivitis if mom had chlamydia or gonorrhea, and as baby passed through the birth canal would have picked that up because chlamydia and gonorrhea, the most common symptoms is asymptomatic, no symptoms at all. So if mom didn't even know she had it, she could potentially cause neonatal conjunctivitis, which is the number one cause of neonatal blindness. And that's why we just do it to everybody. It's a cheap drug, it's easy to administer, and it's not worth the risk of potentially having blindness as a result. The other one is the intramuscular vitamin K that every baby gets. So this one is given to prevent them from having a hemorrhage. With vitamin K, our body does naturally produce it by the liver, but in order for the liver to be stimulated to produce vitamin K, you have to have bacteria in your gut. The bacteria in the gut is what stimulates that liver. When babies are born, their gut is sterile. They haven't been on the outside environment, so they haven't built up that normal bacterial flora yet. So their liver takes a little while to start producing those that vitamin K. So we give them an injection just in case there are any issues with bleeding. The administration of these medications is shown on page 573. Hopefully, if you haven't already, you will get the opportunity to administer these in your clinical sites. So let's talk about some individual systems. Probably one of the biggest ones we're concerned with in the newborn is the respiratory system. That's one of the first things we're looking at. There are multiple factors that play together to stimulate breathing, and I certainly don't want you to memorize all those factors. But there are chemical changes, such as changes in the pH, just them being birthed, and that change and that it causes that change in that intrathoracic pressure. The feeling of the coolness being out of mom's body can stimulate. So there's lots of factors that play into it that cause them to take that first breath. Something that is really important for you to know about is a chemical produced by people called surfactant. So surfactant is almost like a detergent in the lungs. It helps those alveoli open. When we talk about the lecture on high-risk newborns, when with preterm babies, this is a big concern. Before 37 weeks, sometimes babies haven't produced this yet. So if they haven't produced it, it can lead to some significant respiratory distress. So surfactant is an important thing for them to be producing. So if they're having respiratory distress, oftentimes that's one of the first things they'll do is give them some surfactant and see how their respiratory effort as well as their pulse ox does after that to see if that's what fixes their problem. Babies are obligate nose breathers, which means they only breathe through their nose. That's why babies struggle so hard when they get a cold, is because they're not mouth breathers like adults can be if they need be. So, and you'll see as they do a newborn assessment, they occlude each side because they want to make sure that both sides are patent. And they will assess for that. So signs of respiratory distress, nasal flaring is a big one. You see retractions as underlined and highlighted. If you click on that, then it will show you what retractions look like. This is where you'll see sucking in either in between the ribs, under the sternum, under the clavicle, over the sternum, things like that. And that indicates they're using extra muscles to try and breathe. They're working even harder. Grunting is another big one we hear in newborns. In that video with the retractions has some grunting in it as well. Seesaw respirations, which means babies are belly breathers anyway, so you see their belly increase in size as they are or not increase in size, but go up as they breathe in. But if you're seeing, it looks like a seesaw where when their chest rises, their belly falls, and vice versa, that can be a sign of what we call a diaphragmatic hernia, where that diaphragm did not close all the way. If they have apnea, bradycardia, tachypnea, apnea specifically more than 20 seconds. So, like I mentioned already, babies are learning how to breathe. So, expected findings for baby are irregular respirations and periods of apnea. They can have periods of apnea up to 20 seconds, and it's not a concern. If it's more than 20 seconds, that's when you would be concerned. Um, Other signs, if they're having respiratory issues, again, is that central cyanosis. So if their hands and feet are blue, normal. We're not concerned about that. They're just cold. But if they have any kind of blueness in the core, their face, lips, chest, things like that, then you would be concerned of either a respiratory or potentially a cardiac problem. So on page 531 in your book, it does talk about the characteristics of normal newborn respirations. So let's see how you do on this question. A nurse is collecting data from a newborn who is 12 hours old. Respiratory rate is 44 breaths per minute, shallow with periods of apnea lasting up to 5 seconds. Which of the following actions should the nurse take? Should we activate respiratory arrest procedures? Should we report the observation to the charge nurse immediately? Continue routine monitoring or request an order for supplemental oxygen? I'll give you a second to think about it. So in this case, we are just going to continue to monitor. These are totally normal findings in a newborn. They often do have rapid, shallow respirations, irregular. They may breathe and that's why it is so important in infants that you are counting a full minute of their respirations, because if you just count for 30 seconds, you may have picked out 30 seconds where they were breathing 60 times a minute, but then if you keep watching, they slow that rate down or even stop breathing. So it is really even more important in newborns that you are counting for that full minute. So a little bit about the cardiovascular system. So there is a change from fetal circulation to infant circulation. There are several fetal ducts. There is your foramen ovale. There is your ductus arteriosus, your ductus venosus, and basically the biggest thing with these ducts is they are the ductus venosus has to do with shunting to the liver from the umbilical cord, but the foramen ovale, ductus arteriosus, they have to do with basically bypassing the lungs. So babies' lungs, when they're in utero, are not being used for gas exchange. They will have respirations like practice breathing, but they're not breathing for gas exchange. So that blood actually gets shunted away from the heart. Away from the lungs, so it doesn't pass through those capillaries. Well, then as baby's born, takes that first breath, that ideally it should close those ducts so that circulation will become what it's supposed to be as an infant. And then of course as an adult, sometimes it takes a little longer for those shunts to close. That's why one reason why murmurs are pretty common in infants, not always concerning. They will, especially if they are asymptomatic otherwise, not having problems breathing, murmurs are not concerning, and they usually will just watch them to make sure they go away. And usually it's by 6 months or so when those go away. So typical heart rate 110 to 160. Signs of complications. So it's not always obvious. Some of them are don't seem as obvious. So if they're not feeding well, can be a sign of a cardiac problem. If they stay very fatigued, if they're sweating, like I mentioned, babies don't sweat. So when they're sweating, there's a problem. So diaphoresis in an infant could indicate a cardiac problem, as well as some other things we'll talk about. They may have where they actually do turn blue. When we get to pediatrics, we'll talk about more in depth those cardiac congenital defects. We're not really going to discuss those in detail here, but there are some significant defects that can occur, and the more severe they are, the earlier they usually are caught. So as far as their blood cell values, most of them are very similar to adults. Their red blood cells, hemoglobin, hematocrit, are slightly higher for the first couple months or so, but not significantly higher. The most notable one that is really different is the white blood cells. Newborn white blood cells can be as high as 30,000 when they are born, and progressively decrease down to your typical adult white blood cell count of 5 to 10,000 over the first month. So this can make it difficult in a newborn if they are showing signs of sepsis. That white blood cell count might not always be a accurate indicator of whether they are septic or not. And it's because of the stress of birth, the systemic changes going on, the transition from being birthed, and there are certain factors that can make it even higher. So if they're crying, like your babies that are really fussy, that can increase it. Hypothermia, I already mentioned, if they're too cold, that can cause problems. And there's lots of problems that can come from being too cold, one of which increasing their white blood cells, because their body is trying to accommodate for that. And their body, they have an immune system, but the immune system doesn't know what to do yet. So it goes into kind of overdrive with white blood cells that really aren't functioning in the same way that they would be in somebody with a more mature immune system. So, speaking of being cold, the next thing we'll talk about is the thermogenic system, which is a huge problem or potential problem in infants. They are at high risk of heat loss. For multiple reasons. One, their large heads. Their heads are about a quarter of the size of their body at this age. So they have much larger heads in relationship to their body than we do. And a lot of heat is lost through the head. That's why they always recommend keeping a hat on newborns and things like that. The reason we get concerned about heat loss is because it doesn't just cause them to be cold and uncomfortable. It can cause significant problems. So when we're talking about cold stress, your biggest concerns are it can actually cause hypoglycemia because their body is burning so much energy trying to heat it up. They can't shiver, they can't sweat, so their body is still trying to do that process. It doesn't know exactly what to do. It knows it needs to do something, so it burns up all the baby's glucose and they drop their blood sugar. Another thing that often happens is respiratory distress. Cold stress, being too cold, can cause respiratory distress, which of course is a big deal. They can go into lactic acidosis because of the respiratory distress and because of the all the burning of the anaerobic bacteria. I mean, anaerobic, anaerobic metabolism. So lots of problems come from cold stress. So there's four kind of main ways of heat loss. The biggest one we do focus on is evaporation because that's commonly looked at as one that's we can lose a lot of heat from. So, like I mentioned, as soon as they're born, as soon as they come out, they are, as they're assessing, making sure they're breathing, they're drying them off. They want to get all that amniotic fluid off because they can, just like when you sweat, to cool your body off, it's going to cool their body off. When we give baths, you always want to make sure, check the baby's temperature before you give them a bath. If they are already a little low, then you don't want to give them a bath. That wouldn't be the best time to do that. A lot of of times when they are getting a bath, it's good to put them under a radiant warmer or some kind of source of heat, and keep them covered as much as possible so that you don't result in cold stress, because it can happen pretty quickly. It's not something that's a long process. So the other forms of heat loss, things like convection, like having them near a fan or something that's blowing cool air, radiation, being near a source of coolness, like sitting near a window, for instance. And then conduction is probably the second most common one that we get concerned with. This has to do with touching a cold object. So if you just lay them on a cold table, or your cold stethoscope could pull heat from them as well. So making sure that they are maintaining their temperature, generally 97.4 is the minimum for a baby that you would want to see. So let's see what you would do. A nurse is caring for a newborn immediately following delivery. After assuring a patent airway, which of the following actions should be your priority? And we just talked about that. Big priority is to dry that newborn. They can quickly start losing heat, and it can result in some pretty serious complications if they go into cold stress. Remember, they can't sweat, they can't shiver, so they don't have those mechanisms to regulate their own temperature. So they rely on us to cover them, keep them warm. So a little bit about the hepatic system, or the liver, some things that are important about the liver. Iron storage. So babies store about 3 months worth of iron that they get from their mom. So you'll notice a lot of times formula is low iron, or iron is not iron fortified, because they don't need that extra iron. They have enough stores. You'll see as babies get older, they may start to get iron deficiency anemia, especially as they get started on animal milk, cow's milk. So when we're talking about jaundice, so the two big things, jaundice, and then your carbohydrate management. So with jaundice, there's two types of jaundice. So jaundice, you see that baby up in the top right hand corner, is where they have the yellowing of the skin, and sometimes on babies it can be hard to tell, in every race, not any specific race. Even on Caucasian babies, sometimes that yellowish tinge, depending on the light, can be hard to tell. So a really good place to assess it is the sclera of the eye, or inside their mouth on the mucous membrane. Sometimes that's easier to really notice that difference. So the reason babies get jaundice can be for a variety of reasons. When we're talking about the physiologic reasons, sometimes it's because they're preterm. Sometimes it can be related to breastfeeding, and it's not that the breastfeeding specifically causes the jaundice. It's because bilirubin is excreted from the body through stools, and oftentimes breastfed babies don't have as many stools, or the body doesn't have as much an amount of stool, so they're not excreting it as fast as a baby who's formula fed. What we do get concerned about, though, is pathological jaundice. So the difference in physiologic jaundice and pathologic jaundice, other than, of course, the causes are more significant, is time. So if they develop jaundice less than 24 hours after birth, they're going to be looking at pathological causes. There is something wrong with this baby causing this, as opposed to it's just where they're taking longer to excrete and break down the bilirubin. So one cause that can cause that jaundice is that cross contamination of blood from mom to baby. So if mom had those antibodies, didn't get that RhoGAM with her first baby, and then starts to attack this baby, that could be that incompatibility. It could also be an ABO compatibility if there was an incompatibility. Either a baby needed blood products, which is pretty uncommon for babies to get blood products, but there is something wrong that is causing this if it occurs less than 24 hours, or if it occurs more than 14 days afterwards. So typically jaundice, if we're talking about physiologic, is going to be within a few days after birth and go away within a week or two. But if it's less than 24 hours or more than 14 days after birth, then it's very concerning. So kernicterus is what we are concerned with, especially with your pathologic form. So kernicterus is where the bilirubin byproducts build up in the brain, and this can cause permanent brain dysfunction. So usually the way they can test for this is vision and hearing screenings, and they'll start noting that they are having vision or hearing difficulties, and that can indicate that some kind of brain damage occurred because of that pathological jaundice. And these complications are lifelong, not reversible. So it's really important to prevent any kind of jaundice from developing to that point. So that's why any baby who is jaundiced, they will really monitor that and use measures to bring it down. It's going to depend on the baby. When my daughter had jaundice, I just had it was hanging right about 15, which is usually about the minimum level when they want to treat it. And so they just had me coming back every day doing those Billy levels, and never needed treatment but recommended sitting baby near a window or taking baby outside. So in milder cases they can do that. They can just have them get some sunlight, because sunlight helps to break down that bilirubin. If it's more severe and they have to be admitted, so the picture at the bottom, this is where they will put them in the lights, and this will help break it down even more. So you see baby is totally naked other than a diaper, because you want the maximum skin contact with the radiation of the light. And they'll also cover their eyes, because it can be damaging to their eyes to be exposed to that for so long. They also have Billy blankets. So it's a blanket where it has the lights basically in the blanket. And this is one that people can do at home. They can wrap them up in the blanket at home where they're still exposed with their skin. But you can carry them around and things like that. And you don't have the big Billy light incubator to put them in. The last thing as far as the liver is coagulation. I already discussed that vitamin K administration and why it's so important. That vitamin K is not produced yet because their gut is sterile. So we give them a little boost to keep them from bleeding. So the immune system. So babies' immune systems are very immature. The first 3 months or so of life, they actually have a little boost from mom. They have the passive immunity, breastfeeding or not. They get that passive immunity from mom that helps give them a little bit of boost. So when we get to pediatrics, we'll talk about actually infants that are 3 to 6 months old are usually that higher risk. Up to that 3 months, they have some of those passive antibodies. That's why we give mom the influenza vaccine and the Tdap vaccine, so that she can help pass on those antibodies she created against that vaccine to give them a boost. But they do have a high risk of infection. They also have a high risk of reacting stronger to infections. So any baby that is less than 6 weeks of age, if they have an elevated temperature, automatically gets admitted for a septic workup, because the risk is so high, and because they can progress so rapidly. So a lot of times they get monitored, and we watch them, and once their cultures come back and show they're negative, they go home. It's just for extra safekeeping, because they can progress so rapidly. The American Academy of Pediatrics even recommends up to 3 months of age admitting them, because they have a little bit of boost from mom. So if they are having a fever, then it indicates a potential pretty serious infection. So the most common cause of neonatal sepsis, which is in the first 3 months, usually what causes them to get a fever, or one potential cause, is that group beta strep, that GBS. If mom passed on that GBS is the most common cause of neonatal sepsis. So that's what we would be worried about if they had a GBS infection, which can progress really rapidly in an infant. So with infants, what may seem like minor infections to the rest of us as adults can be serious infections for them. So ensuring things like hand washing and good hygiene are absolutely important to protect baby's immune system. So skin, there are a lot of Normal variations you'll see in baby skin. Um, they are not concerning. They'll just watch. So the lower right hand picture is that vernix caseosa. So this is almost like a cheesy coating, greasy type of coating that's on baby skin. And it does actually serve a purpose. It protects the skin. They're inside the womb, floating in water for 9 months. So it keeps the skin from getting dry and cracked. If you look up at the top left picture, that's most likely a post-date baby. So the longer they are in utero, that vernix starts to kind of wear off. So when you have a baby after 42 weeks, they've often lost a lot of that vernix, and it results in them getting the dry, cracked skin. So that vernix is a protectant. They don't often scrub it off right away, because it actually has been shown if you leave it on for a little while, it helps build their skin healing. So some of the pictures you see, I already talked about a couple of them. So the middle top one is something called milia, Milia. So milia are these little keratin cysts they get on the face. They look kind of like little whitehead pimples. Um, they're normal. They go away on their own. You'll hear people call it baby acne as well. Most important thing you can teach parents is not to pick or try and pop those, because just like acne in a teenager, picking and popping at those can result in scarring for the baby. So you want to make sure the parents aren't picking or popping at those. The top right picture is called Mongolian spots. So Mongolian spots are most commonly seen in your darker race population, so African Americans and Hispanics. And these are purplish colored. They're typically on the backside or the buttocks area, but they could be anywhere on the body. And these are a birthmark. They're not concerning. They tend to lighten up as the child gets older, but they don't completely go away. Um, just a birthmark, nothing concerning, doesn't indicate anything. The bottom left picture is just showing you that lanugo. So this baby, in this case, is most likely premature because that's a lot of lanugo. So especially on their back and their arms, you'll see it heavier amounts of that lanugo when they're preterm, and it goes away. And that's what causes them to have the meconium stools, the darker greenish black stools, is where they have been swallowing the amniotic fluid that has the lanugo in it that they have shed, and then they break that down. So sometimes in premature babies, they won't have that really dark stool because they don't have as much lanugo that they have broken down. So some other things you might see, if you see what's called a port wine stain or hemangioma, those are concerning and should be reported. So they are like a clearly demarcated red area, maybe on the face or anywhere on the body. The reason these are a problem is they are highly vascularized and they have to be watched because they can cause functional difficulties for the baby. If it's on the face, for instance, they could get big enough to block the airway. Sometimes they do need to be surgically removed, but they should be monitored. And looked at. Some other nevi or nevus that you may see, they sometimes will get these little pinkish red dots called strawberry spots. These are not concerning. They are just birthmarks. You can have various different colors of birthmarks. Another thing that sounds terrible, but it's actually not concerning at all, is called erythema toxicum. And erythema toxicum, it usually shows up as various stages of macules, papules, vesicles. So they'll have fluid filled, pus filled, and little red spots, most typically on their chest and back, but it could be anywhere on their body. It's just something that happens in babies. It's not concerning. It's not contagious. It goes away. It is not infectious. versus if you had a baby that only had pustules, especially if they only had one pustule, that would be concerning for a skin infection. So if they have a variety of different types of lesions, more than likely it's erythema toxicum. You don't do anything about it. You don't even need to cover it. It's not contagious. Just document and move on. But if you see one pustule, that could be a problem. I had a baby at KidMed that came in about a week after birth, and all he had was about 3 or 4 centimeters over from the umbilicus was this one small pustule. When they went in to pop it, they realized it had tunneled from the umbilical cord that hadn't fallen off yet. The umbilical cord had gotten infected, but it didn't appear infected on the outside. It got infected underneath, and it tunneled up under and created a pustule a couple centimeters away. So pustules by themselves are concerning, but if you have multiple types of lesions, more than likely that's erythema toxicum. Some other things with the skin that would be concerning, things like paleness or pallor, petechia, because that, just like in adults, that could indicate some kind of bleeding dysfunction, central cyanosis, jaundice, things like that. Those different color variations may be a problem. So reproductive system, there's a few variations you'll see with the reproductive system. So when we're talking about females, all of the ova that they will ever have in their life have already been, are in their ovary. So they have all the eggs they need, and they will just grow and mature as they get older and are stimulated by puberty. Some things that you will see that are normal variations. It is normal for females to have a pinkish or reddish discharge from their vagina, almost like a pseudo menstruation. And this is just caused by the estrogen from mom's maternal hormone stimulating that. Fake period. So redness in the diaper is not concerning. It's a pinkish or reddish discharge, not concerning. Another thing you'll see most commonly in girls, but sometimes in boys too, is breast discharge. So they will often have a whitish discharge from the nipples. You'll hear people call it witch's milk. Normal. So white discharge from the nipples of the baby is not concerning. Again, this has to do with the maternal hormones, and the breast tissue being stimulated from that. It's normal for their breasts of both babies to be a little prominent, and they flatten down within a few weeks. Another thing that's actually pretty common is what's called supernumerary nipples, which just means they have an extra. When it's caught as an infant, a lot of times, most of them disappear on their own. They don't always. Sometimes it sticks around and they grow up with an extra nipple, but that extra nipple is non-functioning, and it's not reason for concern. Just document and move on. You don't need to report that to anybody. As far as males, what things that are a little bit different for males. So some of the things that you are checking for the foreskin, how it's adhered to the penis. Typically with newborns, you cannot or you shouldn't be able to retract the foreskin up till about 12 months of age. And when we get to peds urinary, we'll talk about that in a lot of detail, but you can't retract the foreskin at that age. They'll look at the position of the urethra. So we'll talk about with peds hypospadias and epispadias, where instead of the urethra coming out on the tip of the penis, it comes out on the top side or the underside, which can, depending on the severity, can or may not be concerning. And they'll also check the testicles as well. They want to make sure the testicles are in the scrotum, not only for fertility reasons, but undescended testicles can increase their risk of developing testicular cancer later on. So there are multiple pictures in your textbook on page 542, some good pictures that can show you some of those differences. So one thing as far as males was circumcision. Hopefully, if you haven't already, you'll get to see a circumcision performed. One of the ways that they will do, so the picture is showing what's called the Plastibell method. There's different methods. There are pictures of this on page 587 as well. So this is where they surgically remove the foreskin of the penis. There are several scientific benefits. Most people say it's just for cosmetic reasons. There's really no benefit. But there are studies that show it decreases their risk of urinary tract infections. So when we have little ones that come in with urinary tract infections, most commonly it's females, but the second most common is uncircumcised boys. So it does increase risk of urinary tract infections. It also increases their risk of STIs when they get older. So with the circumcision, they leave that plastic ring you see in the bottom of the picture on, and that stays on until it falls off at home. So it's just a plastic ring that kind of holds that skin back and then helps that skin fall off. So some important things to teach parents regarding circumcision care. They will usually give them gauze and Vaseline so they can wrap the penis in the Vaseline gauze so it doesn't stick to the diaper, or at least put Vaseline on the penis itself, because it is going to have some serous drainage. Totally normal, so serous drainage is not concerning. The crusting and all. But it can cause sticking to the diaper, which could be very painful and could potentially cause bleeding. So teaching parents, speaking of that serous drainage, not to pick at it or remove it, it's there to create kind of that scabbing effect. Making sure that they are keeping it covered, obviously changing them frequently so that it doesn't get infected. In order for baby to go home, baby has to, bleeding doesn't have to completely stop. If they just have some scant bleeding or oozing, that's okay, but they have to void before they go home. You want to make sure there are no urethral problems or penile problems resulting in them not being able to pee. On page 588 in your book, it does talk about discharge instructions in detail, but some of those are some of the biggest ones. Keeping it covered with Vaseline, making sure they're peeing, and obviously watching for excessive bleeding, and then keeping it clean. So the skeletal system. So babies' bones are more cartilage than ours, and they progressively ossify as they get older. So that's why you have the bones of the head that are separated that come together, and things like that. So some of the things that they can have related to the skeletal system, they can get fractures. So when you have very large babies, those macrosomic babies, clavicle fractures are not uncommon as they're trying to pass through the birth canal. You can get things called a caput succadium, and a caput succadium is, you'll see this with vacuum bursts sometimes. This is where it does not, where it crosses your suture lines of the baby, and it's just fluid kind of sitting in between those layers, the meningeal layers, and it will reabsorb within a couple days. But you can also get a cephalohematoma, which is the baby you see in the bottom right hand corner. This does not cross suture lines, so you'll see it more localized, and this is where they have a bleed. This could this will also reabsorb and be monitored over time. Looking at their spine, looking at their extremities, the upper right hand picture, that's an example of a club foot where their foot is turned in. So oftentimes they will use braces to fix that, or they'll try to at least, where they will use a cast basically and keep recasting it every couple weeks, where they almost like braces you get on your teeth where it's shifting them. They'll use it to shift their foot. One of the big things that you associate with the skeletal system, though, in babies is hip dysplasia. So this is where in that hip, it's not where their hip is fractured or broken or necessarily dislocated when they're born, but this is where those tendons and ligaments might be too loose on one side or even potentially on both sides, but usually it's one side. And because of that, they can easily dislocate. So the way we test for hip dysplasia that they do with every baby is the Barlow and Ortolani maneuver. And those of you that have seen a detailed newborn assessment, and it's shown in the video, if you watch that newborn assessment video on Blackboard, they push down and try to push the acetabulum out of the socket. That's the Barlow. And then the Ortolani is where they push in, trying to pop it back in. And if they feel a click or a pop, and can and hear it, then that is a positive Ortolani, which means they are able to dislocate that hip, which is a bad thing. It means that they are going to need treatment for that in order for it to stay in that hip socket and those tendons to tighten up. So the treatment for this is the Pavlik harness, Pavlik, which is that picture right in the middle. So this harness keeps them in that adducted position and keeps them and allows those tendons to tighten up. They wear this all day, all night, oftentimes for several weeks, usually about 4 to 8 weeks. And if that doesn't work, they may try surgical maneuvers, but most commonly it does. It does work for them. So some other symptoms you may see besides the Barlow and Ortolani maneuver, the picture on the bottom left that's showing those asymmetrical gluteal folds. So when you look at their buttocks, the folds are different, or they might have their leg or their femur is higher up on that side. So in this child's case, as you're looking at that, it would be the child's right side that's affected. They have the extragluteal folds. You see the knee on that side is a little bit higher, indicating the femur is up a little bit higher. So those can be signs of that as well, even without the Ortolani maneuver. But not everybody or not every baby will have those signs, especially if their hip is in place at the time and it's just where you're able to dislocate it. So the last system we'll talk about is the neurological neuromuscular system. And the best way to assess this is those newborn reflexes. If you don't know your newborn reflexes, make sure you get to know them. You will need to know these. A lot of them are kind of obvious, like sucking reflex. If you put anything in a baby's mouth, including your finger, they will suck on it. Rooting is where if you stroke their cheek, they will turn towards the side that's being stroked, and that's a defense, not defense, a mechanism to keep them alive, basically, responding to finding food. The palm or plantar grasp, where they will put their, and that's the picture you see right in the middle. Anything you put in the center of their hand, or if you touch the center of their foot, they'll kind of wrap their hand or their foot around it. With the tonic neck, that is the bottom right hand picture that you're seeing. So especially if you take their head and you turn it to the side really quick, their arms will stretch out and they look kind of like a fencer, where whichever side their head's turned to, their arm is straight out and then the other one is curved. The Morrow is that top picture. This is also known as the startle reflex. So when they hear a loud noise, or if you pick baby up just a couple inches off the bed and then let them fall, they will fan their arms out and then pull them back. Stepping Babinski, where you stroke the bottom of the foot. These are all important newborn reflexes that can be indicators of neurological functioning as well as muscular functioning. Like for instance, with the startle, if you only see it on one side, it might not be neuro. There might be a muscular problem. It could be that clavicle fracture. It could be that brachial plexus injury or something like that that's causing it. But on page 546 to 549, it shows you pictures of the reflexes with descriptions. So it's really important that you know that. So as far as diagnostics, there's lots of testing that they do in the hospital. That top left picture you see is how they do a newborn hearing screening, where they're actually sending signals and having them bounce off the tympanic membrane to see, to test their hearing. There's other ways. If you clap, if they kind of turn towards the sound, that gives you an idea as well, but it's not always specific. They will also do the newborn screening, the universal screening. This is done in all 50 states by law. It's usually about 20 to 22 tests they test for, which varies by state. The picture of the card is what you see on the right, and then the bottom picture is them applying it. They take the drops of blood and put them in the circles, and it goes to the state lab, and they're testing for metabolic defects, congenital defects, things like PKU, galactosemia, congenital hypothyroidism, adrenal hyperplasia, cystic fibrosis, sickle cell. There's several ones that they're testing for. You should know what is included on the universal newborn screening test. And they do this on every baby. It's just a screening tool. So if anything comes up abnormal, they will contact the pediatrician who will follow up with more detailed testing. But at least it gives them an idea of people that need to further testing. Um, they will also do, depending on the child, they may do a pulse ox screening, especially on your premature babies, is typically the population they do this the most on. When my daughter was in the hospital, they did the pulse ox screening. So what they do is they put baby in a car seat for an hour and put a pulse ox on them and make sure they're not desatting sitting in a car seat because that could be an indicator of some respiratory difficulties. So in the first 2 hours, there's a lot we're doing, but we're still doing things afterwards. And a big part of what we're doing up until discharge is a lot of education. Some parents, if they've had other children, might not need as much education or maybe just some reinforcement, but some parents will need extensive education. So things like making sure they're keeping an eye on their temperature, not necessarily checking their temperature, but making sure they're keeping them wrapped up and what symptoms to look for to potentially show that there is an issue. Looking at their respirations, explaining that irregular respirations are normal. Normal feeding patterns, elimination. A lot of times babies will grunt and strain when they're trying to have a bowel movement because they don't know how to do it. They're trying to learn how to poop. So normal finding, not concerns for constipation. We see that a lot at Kid Med. We would see people bringing in their newborns thinking they're constipated, and they're not. It's just their muscles and their brain trying to learn how to poop. Um, Rashes, normal versus abnormal. How much clothing to put on them? Typically, we recommend wearing whatever the parent is wearing plus one layer. So if it's summertime and parents are in t-shirt and shorts, you can put t-shirt and shorts on baby and just put like a thin blanket on them. Car seats. Car seats are very important. Making sure they are rear facing up to age 2. Um, Car seats shouldn't be expired, which typically car seats expire in 5 years. Should never have been in an accident. Once a car seat's in an accident, even a minor one, it should be replaced because it can degrade the plastic. If it should be at a 45-degree angle, things like that, and always with the buckle, you want the buckle. The clip across their chest around the nipple line. You want to make sure you can put 2 fingers under the strap but not be able to pinch it, things like that. As far as bathing and hygiene, babies shouldn't have tub baths until that umbilical cord falls off because of that risk of infection. Just dry baths basically until then. Teaching them how to do cord care. We don't, it used to be they recommended alcohol, rubbing the around the edge of the umbilical cord with alcohol to help it dry up and fall off. Don't recommend that anymore. Just plain water, maybe a little soap, but if there's urine or stool near it. But other than that, just plain water. Keep them clean, keep them dry. And making sure they're following up. So when I had my son, they made me make the appointment before I even left the hospital and give them when my pediatrician follow up was to make sure I did. But follow up should be within 3 days of discharge just to make sure everything looks good. Abduction prevention is something we are all involved in as well. The top picture shows you that security band. A lot of places now have gone to a security band that actually clips on their umbilical cord clamp, or that's part of the umbilical cord clamp. So you may see them either way. I think the umbilical cord clamp is better because sometimes those security bands, as babies lose weight those first couple days, normal, they always lose weight. They can easily fall off. So some things with abduction, those of you that have been to clinical, you've seen where they will, as they take baby to baby's room, mom has an armband, usually dad or whoever the spouse or partner is will also have an armband. And you want to make sure you're actually telling the mom, read me your number. You don't want to just ask, hey, is this your number? Because sometimes they're not fully awake or they're not entirely listening. And they may say yes without and end up with the wrong baby. So telling the mom, read me the number on your band, and that way you can match the numbers up and ensure it's the correct baby. Um, and teaching mom to check the ID of everybody who comes in her room. So even housekeeping, or x-ray, or not that x-rays happen that often, but anybody that comes in there, they should be checking the ID. And if they don't know who they are, there's nothing wrong with them getting the nurse to confirm, yes, that person belongs there. Because people who abduct babies are really smart about it and find ways of impersonating hospital personnel. So if there's any concern, mom should follow up and ensure that. Another thing is encouraging parents not to post pictures of their newborn on social media while they're still in the hospital. There are people that abduct babies that actually look for those. So when they see you have tagged yourself at, say, Chippenham Hospital, they know where to go. They know your name. They can pretend like they know you. So best to save those pictures for after discharge.